What's up, YouTube? Welcome back. Dr. Chad Connor here, board certified internist, current chief medical resident, and soon to be cardiology fellow. Today, I want to show you guys how to place a central line. So the first thing about a central line is knowing your kit and what's in the central line kit. So we're going to go through that really quickly here. When you open the central line kit, I have one that's already open because we use it as demonstration on our mannequins. So I'll go through what's in it, but this kit does have everything that would come in your normal unopened kit. The first thing is your sterile gown and your sterile drape. This sterile drape you put over the patient to provide a sterile barrier. A central line should be performed as a surgical procedure. Anytime you break the skin, there is a high chance for infection, so you want to make sure that it's as sterile as possible. Also in the central line kit, you'll find gauze to control bleeding. You'll find some iodine swabs to help with sterilizing the field. You will have your sutures. And here is sterile gloves. You have your guide wire. This will go into the central line. You have your triple lumen catheter. This is the actual central line, and this is what will go into the patient's internal jugular or femoral vein when you're placing the central line. You have your scalpel. This is for nicking the skin in order to advance your dilator. You have lidocaine. This is important for anesthetizing the area so it's comfortable for the patient. And you have your introducer. This is the plunger and syringe with the needle for performing the central line procedure. There's a number of other things in here, such as extra needles and extra syringes for injecting the lidocaine, but we'll get started here. So when you're placing a central line, it's really important to know why you're placing a central line and that there are a number of potential complications. The patient should be well informed as to what's about to happen so that they can make the most educated decision. A central line is an invasive procedure. With any invasive procedure, there's the chance of infection. There will undoubtedly be some discomfort and pain. There's a chance for bleeding, there's a chance for vessel injury, nerve injury, and a pneumothorax if you're performing the central line in the internal jugular due to its proximity to the lung. Pneumothoraxes are not nearly as common as they used to be because we do use an ultrasound for all central line insertions these days. But in the olden days, prior to ultrasounds, it was much more common because it was going blind and the needle would frequently make contact with the apice of the lung and could cause a pneumothorax. Again, it doesn't happen very frequently these days because of the ultrasound. So we'll get started here. So the most important thing is using your ultrasound to find the vessel. So you put the ultrasound on the patient's neck and you look at your ultrasound screen. Here I'm seeing two vessels. I see the vein and I see the artery. In order to differentiate which one is which, you need to place a little bit of compression on the patient's neck. The vein will completely collapse where the artery will not completely collapse, and you will frequently see some pulsation in the artery. That's due to the blood pressure and the artery being a high pressure system. So here I can see my vein in the middle of the screen and I can see my artery down to the left. This is perfect anatomy. This is not what you will see on every single patient, but for the purposes of today's demonstration on our mannequin, he does have perfect anatomy. So good, so now I've found my vessel and where I'm gonna go. The next thing I do is I'm gonna inject the lidocaine. So I'll take my lidocaine and I'll make a wheal in the patient's neck right under the subcutaneous skin so that the patient is anesthetized and does not feel any pain. With proper anesthetization, the patient should only feel a little bit of pressure with performing the procedure. The next thing I want to do is I want to get my needle ready. So the grip is really important because you want to make sure that you can pull negative pressure on the syringe as soon as you enter the patient's skin. This will let you know when you've gotten into the vessel because you will immediately get some blood drawback. It's also important to make sure that the bevel is face up when you're performing this procedure. You will go in with your dominant hand with the needle and you will hold the ultrasound with your non-dominant hand. I like to rest the ultrasound hand on the patient's chin for stability, and this way I won't find myself drifting all over the place with the ultrasound as I'm performing the procedure, and I'm able to keep the vessel in the middle of my ultrasound screen. So we'll get started here. I'm going to take my needle at about a 45-degree angle in the middle of the ultrasound, correlating with the middle of my ultrasound screen. I'm going to slowly insert the needle. As soon as I enter the skin, I'm pulling negative pressure on the needle, and now I'm going to find my needle tip with my ultrasound. So this way I can watch the needle go into the vessel. I see my needle right on the top of the vessel here, and I'm going to advance and I got a flash on my plunger. I feel the blood come into the plunger, and with my ultrasound, I can see the target sign in the middle of the screen there. So the next thing I do is I'm going to put the ultrasound probe down, and I'm going to grab my needle. I'm going to confirm I'm still in the vessel because there is a good amount of movement that happens there, and I'm still getting blood, so I know that I'm still in the vessel. The next thing that I will do is I will pull this plunger off, and I will grab my guide wire. The guide wire gets advanced into the needle, and you will advance the guide wire to about 20 to 25 centimeters. That is shown by black lines on the guide wire. One black line is 10 centimeters, two black lines is 20 centimeters, and a solid black line is 30 centimeters. So I'm advancing, but I'm feeling a little bit of pressure. In order to get through the pressure, you can flip your hand over, or you can flatten out the needle, and that way you can continue to push. You never want to push against pressure because you can cause vessel injury. So here, I'm at about 25 centimeters, which is more than sufficient. I'm going to pull out my guide wire housing, and now I have my hand on the guide wire. You never want to let go of the guide wire, because if the guide wire gets sucked into the patient, it becomes a vascular surgery emergency and can cause very dangerous arrhythmias. So I have my hand on the guide wire. I'm going to pull my needle back to my back hand, and I'm going to re-grab the guide wire, and now the needle is out. Now my guide wire is in place, and I want to confirm that I'm still in the correct vessel. So I grab my ultrasound, and I look, and I see a shadow within the vessel showing that it is my guide wire within the vessel. And I turn my ultrasound probe, and I look at it in the transverse way. And here, I can see my guide wire perfectly within the vessel. So I know that I'm still in the internal jugular. Next, what you would do, I'm not going to do it on this mannequin, but you would take your scalpel and you would nick right next to the guide wire, and that allows the skin to be broken so that you could advance your dilator when it's time to advance the dilator. So now that I've nicked the skin, I'm going to take my dilator, and I'm going to put my dilator on the guide wire. My dilator is on the guide wire here, and I'm going to advance my dilator into the patient. You only need to go about halfway in, and if you do feel a little bit of pressure, you can twist the dilator in your hand, and that will help it advance. Now when you're taking the dilator out, you want to make sure that you don't accidentally pull your guide wire out. So good, so now I'm dilated. A patient will typically be bleeding a little bit now, and that's why you have the extra gauze to hold against the skin here to prevent the bleeding. And now you can put your triple lumen catheter on. You'll see the triple lumen catheter has 3 ports, a red, a blue, and a white. The red or the purple brown port here is where the guide wire is going to come out of, because that's the center port. So you want to make sure there's no cap on the red port. You put your guide wire into the triple lumen catheter here, and you advance it all the way until you see the guide wire coming out of the red port. Then you can grab the guide wire at the back of the triple lumen, and you can advance your you can advance your triple lumen catheter into the patient. You're going to go all the way in, and then you're going to pull your guide wire out. So now I have my guide wire out. You want to check that you're in the vessel by trying to draw back on all of the ports, and I am getting blood return here, so I know that I'm in the vessel. Once you have the triple lumen catheter placed, you cannot use it yet until you get an x-ray. You want to see that the tip of the triple lumen catheter is at the cavo-atrial junction, and that confirms proper placement. So that's how you place the central line. I hope you guys enjoyed the video and found it helpful. If you did, please like and subscribe. And if you have any questions, leave them in the comments below. Until next time, peace out, everyone.